So I'm going to introduce Amanda Cowan, she, her. Amanda studied in the UK, obtaining her undergraduate degree in sociology and social work. While working for the National Health Service in harm reduction programs, she went back for her master's in addiction and mental health, focusing her dissertation on the link between opioid use and ability to accurately assess emotional states. Amanda has worked in a multitude of substance use settings, from community-based mutual aid programs, jails, hospitals, and outpatient treatment, to helping implement syringe exchanges. Amanda's specialty is harm reduction, where she provides technical assistance and capacity building to agencies. Amanda's current role is at CLARE Matrix as Director of Community Engagement, focusing on removing barriers to those accessing treatment for opioid use or stimulant use disorder, decreasing stigma, advocacy, and ensuring equity in treatment. Amanda is chair for the Integrated Health Community at Los Angeles Regional Reentry Partnership, working on health equity for those impacted by mass incarceration, as well as commissioner representing Supervisor Sheila Kuhl on LA County's Alcohol and Other Drugs Commission. Amanda Cowan, everybody.
Hi, my name is Amanda Cowan. I use she, her pronouns, and I'm really excited to be here today to present on structural violence within medicine. So I'm going to share my screen. You'd think I'd be good at this by now. So I just wanted to say, I think from the beginning, to jump in to just say, again, thanks for having me. But that also that people here, I really truly believe, have a deep commitment to wanting to shift the systems that have othered, excluded, and harmed people. And so my hope at the end of this, at the end of the conference, is that we all kind of leave with this understanding that it is really our collective responsibility to move from reinforcing to dismantling oppression within our professions and then also within broader society. And so, you know, that from today and your continued work and ensuing conversations, really understanding that people in the healthcare system can serve as agents of change and can really work to ameliorate the issues of systemic oppression. Doctors, nurses, treatment providers, all of us that are on this and engage in this work, we're no different than anybody else in the sense that we have all been socialized with the understanding and the perception of drug use that has been crafted by the war on drugs narrative, right? And so the perception of people who use drugs has really been led by the media or the criminal justice system. And so the portrayal has been just overwhelmingly negative. And so there's two kind of narratives of drugs that exist and come up. And it's that one is interdiction, so drugs and crime, and then the other suggesting that the inevitable consequence of drug use is just devastating effects. And so I think most of us have internalized these narratives, and I really think the only way to engage in truly patient-centered care is to unpacking these belief systems. So as we're all acutely aware, our social service system is, there's no safety net. It's fractured and siloed. Additionally, our understanding of substance use and substance use disorders are consistently evolving. You know, most people that use substances are self-managed users, and it leads to a deficit in public understanding. And so around 85% of people who use substances are never going to fall within the criteria for addiction. And so that the 15% who are on the spectrum, let's say, of problematic or drug use tend to fall within these contextual risk drivers that significantly increase their danger. So the set and setting of the substance. And so when we think of that from the perspective like poverty, increases the risk. And so also to just kind of frame this and keep in mind that I think we have a real history, and we tend to do this a lot, where we pathologize people. And for many, that substance use is a really, really skilled way of navigating life circumstances, of navigating trauma, and meeting people's fundamental deep needs. And so that our knowledge, again, on drug use really has been manipulated and seen through this one lens. And through this prohibitionist drug policy, the link of the perception of people who use drugs, the perception of drugs, and then drug policy, really just creates this vicious cycle. And so under a prohibitionist framework, a person who is using substances is engaging in an act that is illegal, which increases stigma. It makes it even easier to discriminate against people who use drugs, and it really enables, to the detriment of everyone, it enables policies that treat people who use drugs as scapegoats for wider societal problems. And so if the individual is entirely to blame, then there's no urgency to address larger problems of inequality, poverty, breakdown, or any other social or structural determinant of health. We see this play out just even with this, at the moment, with fentanyl, which, a lot of hysteria around fentanyl and this repackaging of drug war propaganda. And it's allowed people, or given them, a sense of permission to be openly xenophobic. And again, this is propaganda that is founded and propelled by racism. And so we keep doing this dance where instead of having to reflect critically on our practices, we can put the blame on this distant other, this other person, and keep this divide. So stigma and criminalization are enmeshed. We have to remember that. And they prop each other up. And stigma is a form of social control. It's a form of power. It's a silent violence, and it leads to cruelty, and it leads to a lack of care. And I think most of us have been taught that power is power over, when the reality is, for me, is that true power is moving to this understanding of I see you and I stand with you. So we'll go through some of the harms in medical spaces, and I know this is not an exhaustive list. I think it's somewhat comprehensive, but if we were to speak to people, I know we would come up with a much longer list. I'm sure we're all very well aware of how stigma interacts with healthcare, in the sense that it undermines diagnosis, treatment, and successful health outcomes. There's a plethora of research around how stigmatizing attitudes found in medical spaces towards people who are using substances, and how that negatively affects their healthcare, how it can impact the delivery, it can result in treatment avoidance, it can avoid an interruption. So we need to remember that people are navigating these spaces, and they come up with really creative ways to avoid being harmed. Stopping engaging in services, that's a strategy to protect yourself. Additionally, stigma leads to a lack of feeling of self-efficacy in others. We see these manifestations of stigma all the time. They're quite widely documented. And I'm sure within your own practices, and you've seen this in your own workspaces, that sadly it bleeds in, and it leads to denial of care, substandard care. I've heard of physical violence, verbal abuse is rife, to more subtle forms, maybe to making certain people wait longer, or passing their care off to somebody else, intentionally harming somebody when we're collecting samples. And this stigma and this distrust erodes any potential at a therapeutic alliance. And so there's a few things I think we can pull out in this list. One is also just this underdeveloped infrastructure. So people are navigating and straddling all of these medical homes, that there's no one system. And we also use this as a way to not engage in services with people. We ping pong them. So if we say, okay, well, you have a behavioral health need, but there's also a mental health diagnosis, or substance use, and it becomes chicken and egg, and then it's this ping pong back and forth, and no one has a safe place to land. You have to treat your mental health first, or you have to treat your substance use first. And it becomes this circle in which no one gets taken care of. Health insurance, so poverty and also racial stratification of who has access to medical care, who's believed in medical care, especially like when we look at pain medication and we understand who is believed to have access, who is believed to have actual pain, and then who has access to pain medication. So we see this with chronic pain patients. We also see this quite consistently with people that are using illicit opioids, this idea that they can't possibly be in pain, they can't hurt themselves. It's pervasive. And so it really leads to this massive disruption. You know, if we look at who's a patient and who's considered a criminal, this is a fraught societal issue, and it doesn't stop because we're in medical spaces. It very much shows up in doctors' offices and hospitals quite consistently. We see this with prenatal drug screenings, right? When we look at mandated reporting, and we understand that, again, medicine then by default becomes an extension of the police state. When we look at the data of who is being randomly drug tested, you know, it's in black and white. You can't deny that. So there's, again, like this refusal to prescribe certain medications, refusal to have discussions around other things like PrEP, or refusal, like I said, you know, pharmacies and medical homes, a refusal to sell syringes. I've seen this myself, shaming and bullying and phlebotomy. So people, maybe, you know, phlebotomists can't access a vein as easily as they would like, and there's a lot of negative comments that might fly at the person. Not using lidocaine, so again, this kind of punitive way of going about treatment, deciding that somebody can't possibly experience pain, but also intentionally trying to hurt the person. Intentionally being rough with collections, and then diagnostic overshadowing. So a real dismissal of what brought that person in. And instead, this focus solely on their substance use. We're only going to talk about your drug use, attributing all of someone's symptoms to their substance use, not listening to their actual chief complaint. What is going on? What do they need to discuss? Making everything about that drug use. And then really strict appointment scheduling are high barriers. So I think there's this narrative of hard to reach patients, which is also, I think, pejorative. And it puts the onus on them instead of it being the onus on us, and the reality that we have really hard to reach modalities. We are hard to reach as centers and facilities. Also emotionally hard to, not just physically with our kind of barriers, but emotionally hard to connect and kind of put this space between us. And so I think this comes up all the time, you know, and to add on to the pejorative language, frequent flyer, drug-seeking behavior, all of these things, people hear that and they take it with them and they stop coming. And so this is from Miranda Fricker. And so what this is this form of injustice is essentially a practice of discrediting people as knowers based on their social identity. So there's not a lot of research into how this plays out with people who use drugs, but we know that it has a profound effect on their healthcare. We know this through conversations that we've had and anecdotally, but just, you know, think of your own experience, and when you've had a really troubling experience with a provider and you weren't listened to and you weren't believed as the expert in your own life. How does that show up? Do you go back to that provider? I wouldn't. I don't. And people with, you know, this creates this narrative of people with substance use routinely assumed to be dishonest by nature, or doctors questioning their motives for seeking certain medications, or they're regarded as like poor historians. So there's a lack of understanding of how substance use actually plays out in somebody's life and the potential good it brings them and the safety it might bring them, the way that they're able to experience joy or pleasure through their substance use. That's a form of an injustice, because not understanding that substance use is meeting this deep need that somebody has expressed, but also just the general lack of belief. And I don't think that most of them are intentional. I do think it's just this ingrained behavior. So like racism, it kind of often emanates unconsciously from the basic structure in the cultures and the systems that they take place in. And so some of the ways that we can support people in medical spaces is our notes and our charting. What's really important to put in there? What can be left out? Think about how the next, the person after you is going to read that chart and what decisions they might be making based on that. Talk to your colleagues. Talk to them about everything. Talk to them about what you don't understand, who you're struggling with. Because I think when we don't talk about who we're struggling with, we don't talk about our own fears and insecurities about, I maybe don't know how to engage with this patient population. All that happens is that anxiety and that fear gets put onto somebody else, and it's taken out on the participant or the patient. Talk to your colleagues also about these cases, right? Because we don't have we have these siloed health systems. We don't talk to the person that's taking care of them for something completely unrelated or maybe a little bit related. And we really need to do that. We need to have better communication so it doesn't fall on the person receiving services. One-to-one conversations when we're talking directly to people, remembering that they're the same as everybody else, that we want to be treated with respect. People want to be seen, people want to be heard, grounded in humanism. This is another human being. What are some of the barriers that live within your system? What hospital systems need to be changed? What policies and procedures maybe unintentionally uphold violence in where you work? Harm reduction interventions, right? So we can do these downstream drivers as a tool to build trust and rapport. Going back over our policies, making sure that it really is through a trauma-informed lens, and then hiring people with lived or living experience. And I know there's a real focus on lived experience, and I do think it's really important that we start moving the conversation to living experience, people that are actively engaging in substance use. Okay, so trauma-informed care. This is SAMHSA's model of trauma-informed care and their core principles. I think it might be more helpful to start to go from what trauma-informed care isn't. So duplicative assessments and paperwork. We need to have conversations. Back to the conversation part. Maybe we can learn our paperwork, what really needs to be asked and answered. And we can have this in a discussion and then transcribe and relay that information after, instead of being there with a clipboard in front of somebody and not making a connection. It's also just it's a waste of time. It's traumatizing for people to have to continually redo and discuss and disclose their trauma over and over again, especially to people that they don't have a relationship with. There's no anchor of safety, and for services that they're probably never even going to receive. So we just keep asking them for more and more paperwork. I think we should trauma's ubiquitous. I don't want to have the narrative that everyone that uses drugs has had adverse childhood events. I think there's a large body who have experienced trauma in their substance use, or have experienced trauma in medical spaces, have experienced trauma maybe later in life that might have nothing to do with substance use. So if we just go from the idea that unfortunately in this country, trauma is ubiquitous, and if we establish or assume that they have, assume that they have a history of trauma and then work to establish a relationship based on safety and connection. That's probably the way that we need to do this. So also not going from a deficit model, going from a strengths model. So understanding and talking about the person's strengths. So their courage to come into these spaces, their courage to seek treatment, whatever that might be, their resourcefulness, how people have navigated life. And I think it helps to provide for them, our patients, our participants, I say participants, because I'm not in a medical space right now, to understand and believe in their own inherent ability, their own innate wisdoms. And so, you know, for us to understand and remember that people are carrying around compounded trauma, it's been part of their journey. Remembering that everybody wants to be seen and heard, and they want to be seen for all that they have experienced to get where they are. And then especially when we're talking about people of color, that includes the racism that they have experienced and endured throughout the trajectory of their life. So we have this group of folks who have been continually harmed and invisibilized. And it's our lack of understanding of what trauma actually is and how trauma presents. And so you know, something that took me a while to understand is, I think a lot of times the behaviors that we maybe say we don't understand, or that seem big or seem potentially scary, are really adaptive, incredible ways to get your needs met. I will make you see me. I will make you engage with me in some form, right? It's a brilliant adaptive strategy. And I don't think we realize that sometimes trauma is showing up in those places. So structural violence, again, you know, I'm trying to break this down a little bit, the forced choice, discrimination, and then limitations to, you know, healthcare information. But the term structural violence doesn't refer to direct or intentional use of power. It really concerns situations in which individuals or populations are harmed and their needs are impaired due to the oppressive and the unjust social conditions in which they live and learn. And so structural violence is a form of violence created by and perpetuated by social arrangements. So historically rooted social structures and relationships, political organizations, economic opportunities, et cetera. And so all of these arrangements are based on unequal distribution of power among different categories of people and favor some groups over the others. And structural violence really does create and stabilize really harmful social systems. It limits the chance and constrains the agency of those that are kind of deemed less socially valuable. And so although it manifests itself in all fields of social reality, including the discriminatory laws and economic conditions, biased cultural beliefs, the reality is that most structural violence, unlike direct violence, is invisible and unquestioned. And so I think what makes it invisible and what makes this unquestionability kind of possible is the fact that structural violence is just so deeply ingrained in our social fabrics that it becomes commonly accepted as the way that things are, or that it's even considered a necessary form to continue our conditions of social and political order. And so health injustice really intersects and it operates in conjunction with other forms of structural violence. So economic, political, legal, all of these things, these social disadvantages that exacerbate and perpetuate health injustice. So, you know, the ultimate health prevention model is not just to alleviate suffering, but to keep it from arising in the first place. So I think for us to, you know, continue and follow this through line that alleviating harm involves understanding the ripple effect that social structures have on our human ecology, and that we are all engaged in it and are all responsible for it. And so some of the harms in treatment spaces. So for one, I think before we can even attempt to shift kind of general population stigmatization of drug use, we really should be looking internally, and we need to be dismantling the exclusion and shaming within drug treatment and recovery communities, which pushes people out of services, it pushes people to the margins, and it disenfranchises them from the support that they could get to potentially stabilize or save their life. The reality is not everyone sees treatment the same or recovery the same, and that is absolutely okay. Everyone should have the autonomy to choose what recovery or not recovery, what substances they put in their body or don't put in their body as their own choice. Yeah, and just, you know, again, sitting in this framework that if we don't look at all of the social inequalities that exist and the stigmas that exist that are the reality for people, then we can't really understand their vulnerability to and their capacity or interest in embracing some other modality, some other engagement, a different way, right, of treatment or recovery. That it's just not possible if we don't acknowledge those other things. So kind of going to drug court, you know, going back to how I started in the beginning is understanding kind of where drug courts come from and what their belief systems are. And so drug courts on the whole are not, don't believe in harm reduction modalities, and they really think of drug use as the root cause of criminality. And the reality is plenty of people use drugs all the time with no crime. And so, but the crime becomes the drug use because we're in this prohibitionist society. And so again, when we focus solely on the drug, then we don't have to deal with these root causes. And so when I laid out, you know, what structural violence is lack of choice is violence. And so this is what happens in drug court. Is this lack of autonomy, lack of agency, lack of choice. You know, I don't know any other medical space where we outsource our expertise. So somebody else that has nothing to do with substance use becomes the expert. And so that's kind of what happens in these situations, and drug courts on the whole tend to favor one form of medication, a form of medication that's not efficacious for most of our population. You know, and without having these choices, it's this violence. And also just like, you know, in any other setting we go to the doctor, we go back, we tweak, we add on medications, we move back and forth until we find the right combination. And this doesn't happen in this capacity. And so it becomes a way to really restrict someone's choices. Also looking at, you know, who the referral sources into drug courts, where they come from. About 25% is a condition of their parole or probation. And another 25% are referred from like social services, employers, and schools, right? So we have to think about those reporting mechanisms and what happens when somebody doesn't engage in treatment in the way that they want to. What's the consequence of that? And then how does that become a coercive space? So substance use disorder is present in about 65% of all people who are incarcerated. And just kind of this reminder that the mechanisms of incarceration and how they exacerbate the conditions of an already medically disenfranchised population. And so when we look at the treatment space, continue looking at the treatment space, we have to remember, I think, that treatment is an industry. People are making money off of treatment spaces. There is a substantial lack of oversight in many facilities and a real exposure to harm. So we can start with Synanon. I think it's the modern creator, essentially, or the biggest influence of the confrontation model, so behavior modification model. If you don't know the history of Synanon, I would highly encourage you to research it. With the unbelievable abuses and violations that happen there. But Synanon was really kind of the beginning of intentional kind of drug treatment communities. And it created and opened the door for the troubled teen industry. So these boot camps and wilderness programs that are completely based on behavior modification and confrontation models. Senacor is like a new iteration of Synanon. Extensive labor violations, and this is not just unique to one treatment facility. So if you go to Reveal News, Reveal did an incredible series. They have an unbelievable podcast about the labor violations specifically at Senacor, but they have on this website, I think it was over 300 labor violations in treatment centers. And so people that were expected to work all day, every day, to not get a cent of their pay. And it was seen as this trade-off between treatment. And then human trafficking and patient brokering. So it's called the Florida Shuffle, or known as the Florida Shuffle, and essentially it's an insurance scam. So rehab centers are, especially private rehab centers, are plagued by unproven approaches, lack of evidence-based practices, and really predatory business practices. So the link here, it's a really incredible panel that USC held, but you can Google this, Google the Florida Shuffle. Mother Jones has an incredible article. But essentially, people are given insurance, all parts of the country. They're flown out, so they're crossing state lines, which then becomes a federal offense. It's human trafficking. And they're told to go into these treatment facilities, and they, milk their insurance as much as they can. And let's say the person has a period of sobriety, and insurance is going to cut the person off. Say you're ready to go back into the world. We're not going to continue to pay for residential treatment. What happens is these brokers come in, they tell them, hey, we're going to take you out for a couple of days. We're going to have you relapse so that on your urine tox, it's going to come back as you have used. And then it resets the cycle, right? So people's insurance goes back, somebody goes back into detox, back into treatment, and the cycle continues. And the cycle continues until someone dies, or the cycle continues until someone's insurance runs out, and then the person is just left on the street to fend for themselves. There are a lot of harms in our treatment spaces, and I think it's really important to highlight and elucidate what they are so that we can understand why people might not be engaging. When we view addiction through the lens of a disease model, the reality of trauma that is being held in people's bodies really can be completely overlooked. And then just trying to reemphasize that vital, incredible adaptive function that substance use has served for a lot of people. And that's not to say that it comes without harm or make light of it, but just to understand for a lot of people, it is a way of operating and being involved in a seriously fragmented society. It's a way of adapting to dislocation. Dislocation is unbearable for people. And we know this, right? Because we think of like punitive punishment, extreme form of punishments are solitary confinement, exile, ostracism, banishment. And we do this as well for people, that we push them out and we dislocate them. But also in the traditional treatment model, people have to desperately crawl through hoops to get better. And when we do that, it has absolutely nothing to do with helping, and it has everything to do with outcomes. So we stick to these really rigid treatment plans and goals. And we say things like the person is not compliant with their treatment planning when they don't meet these set goals. So for me, I think the reality is that when a treatment plan doesn't go to plan, it's that maybe we need to redo this. What is needed, what's not needed, what works, what doesn't work, reminding and remembering that people are the authorities in their own experiences. And so what we might see as non-compliance or non-compliant behavior, it's protest behavior. People are going to find ways to reassert their agency and get people to listen to us, and that includes us as their providers. So what happens a lot in these treatment spaces are these one-size-fits-all models, lack of cultural competence, the inability to realize the impact of oppression, marginalization, and exclusion, inability to provide a safe space for people with intersecting multiple marginalized identities, these white-centered treatment modalities. When we solely focus on recovery, we have to remember that that is a form of privilege. A lot of people are not going to have that opportunity to parse those things out. And I think we really have to be mindful of the health disparities that exist. And to deliver this kind of true health equity is acknowledging the glaring disparities as to who in these intentionally excluded groups has access. Lack of agency and autonomy. So, the physician or the provider in these cases is the credentialed expert, and therefore the locus of control sits within them. And even from the best intentions and this place of wanting to help, there's a lot of restriction of agency because of the labels. And so that has a lot of consequences for those that we are working with. It really limits that person's ability to define and redefine their own narrative around their drug use or personhood. I could go on, but for many, the dominant treatment modalities of, abstinence-based programming is really harmful. The tenets that are used can be seen to employ shame and fear as primary ways of and tactics of encouraging sobriety, that it really does rely on Christian-rooted dogma. It puts the burden of the individual for their issues and has really no way or means or intention of engaging with the systemic issues that perpetuate someone's need for recovery. They don't access accessibility or they don't prioritize accessibility for meetings. A lot of times the literature can be seen as full of ableism, and people are shamed for not showing up and being of service 100% of the time. And so again, it's this matter of privilege that for a lot of people, that's just not a capability. And so traditional recovery in that model maintains so much control and resourcing over how people heal. When we look at equitable access to medication, I think it's really, really important that we acknowledge that providers can act as gatekeepers, that providers hold institutional power and can either allow somebody or not allow someone access to resources. And so there's a few things here. It's who has access, and we can look at Dr. Hansen and Dr. Friedman's work on access to medication and kind of this stark contrast in who has access to buprenorphine and then who has access to methadone. Additionally, the narratives around methadone and buprenorphine, but especially methadone, between kind of the restrictions and the oversight of the DEA, it just really creates these obstacles, and it stigmatizes these medications by saying that they can't be used like other medications. Methadone is the most regulated medication, and it sits essentially within its own system of healthcare. And so methadone is an incredible medication when it is done correctly. And when it is not, it can lead to another avenue of creating disciplined bodies and disciplined subjects. And so I think when we look even at the verbiage, we infantilize people with methadone. We call take-homes privileges. And it puts people in a really precarious situation that their behaviors or the perception of their behaviors dictate their ability to be physically well. It dictates their ability to be psychologically safe. So our needs or their needs then are anchored in someone else, right? The doctor, it's pretty disempowering, and it leads to a real lack of safety at sometimes because you become dependent and beholden on another. And so I think we have to be really careful in these situations is how we address methadone and how we understand access. Insurance and monetary barriers, faith, non-faith-based, right? Just the idea that we don't really have places for people that maybe they want to go, or the parts that are really important for them to acknowledge while they're there. Decolonizing substance use, that decoupling white practices in recovery. I'm just checking myself for time. Okay, I gotta move on. But basically, a harm reduction approach in medical spaces is how we speak, how we listen, and how we approach. And so one-to-one harm reduction really begins with honoring that person. How is it getting there for them? Asking those types of questions, addressing their acute need, not talking about their substance use if we don't need to be talking about it. And what would they like to see happen? What's their priority? So the great thing about motivational interviewing and how it intersects with harm reduction is just how it engages in supportive conversations. So these are some examples of supportive conversations. But I think it's also really important to understand the difference between a harm reduction praxis and harm reduction interventions or modalities. And so I think sometimes when we attempt harm reduction work, we're using modalities and not a harm reduction as praxis. And so, something like an example of safer use education is incredibly important, and it can be very, it's very well-meaning, but if it doesn't meet that person's needs, or it's a repeat or of information they've been told time and time again, that doesn't help them. So we really need to understand how harm reduction involves being really flexible, and having explicit conversations with participants about their desires and their needs. So, all of these kind of as a framework. Some more things to kind of consider is what is harm reduction in praxis for you? So the theory versus the strategy. We can think about what are our shared goals, and this deep understanding of institutional and systems interplay. And so just remembering that, medical systems are really complex, and they're tricky to navigate, and they can be really rife with discrimination and stigma. And this reinforces that marginalization. And we need to remember that people who use drugs, they can make decisions outside of their substance use. We don't need to do things solely based on that drug use. And so again, with this harm reduction praxis, it's like, how can we sit and ask deeper questions? How can we see the really complex and layered lives that people manage and live? If we create a system where people who use substances can't be honest about their usage to professionals, and we deny them care, then we create a system in which we kill people. Medical and social conditions take place because of and outside of substance use. And so that's really important, I think, to anchor in is how fundamental these relationships are, that they have the potential to create or exacerbate harm, and they also have the ability to change and modify behaviors. And then I think a thing for me to always think about is like where harm reduction lies is for you is like having conversations around like, are we going to train a kid in overdose reversal? And when I say that, does that make you uncomfortable? Where does that show up in your body? Why is that, right? So how old would they be if we wanted to show them how to use an EpiPen, et cetera? And so lastly, some questions for reflection that I think are quite important, understanding how our biases show up, and then how we can make changes. We can really engage with these systems of care. And I think it's really important to recognize the resistance to medical violence that is ongoing. So communities who have borne the brunt of this are always and always have been at the forefront of resisting it, and they've often been criminalized for that. And so most of the time, these communities that are engaging in this resistance work have actually not just improved health for the community the conversation was maybe about, but health for many others, a much broader version of health. So I think, we look at the Black Panther Party in the 70s, and here they're doing their sickle cell training program, and they screened around 10,000 children, and it changed the way that the Nixon administration pledged to take care of this. We see a die-in in front of the FDA to it pushed for the FDA to release more antiretroviral medications. We look at the Young Lords, so they actually did a hospital takeover in the South Bronx, the Lincoln Hospital. They understood the issues that were coming out of this hospital, and they decided to go in and demanding accessible healthcare. They also pushed forward treatments like auricular acupuncture. Then we have Moss Park in Canada. Essentially, the government had waited a substantial amount of time to release funding, and they just went ahead and opened up a tent in a park that had an excessively high number of overdoses. And then we have the Drug User Liberation Front, who providing like compassion clubs, essentially providing care and drugs that are not tainted or poisoned. And so really just to wrap all of this up is, I could go on for hours and hours if you couldn't tell, but to wrap all of this up is for us to be aware of how insidious, systemic, racial and ethnic biases are, how they influence our system and they impact our individuals. So our systems of care end up replicating and amplifying power and privilege as it exists in our society. And our words have power. They have the ability to drum up fear and lead to policy implications. They can other and force people to the absolute margins. They can be used to dehumanize each other. So I think if we can change the conversation to understanding how our faulty systems, someone's entire experience in how they've existed in the world and interacted with all of these systems like welfare, school, healthcare, housing, et cetera, how do we support people that are currently living this experience themselves? I end all of my conversations pretty much this way. It is fundamentally important to remember that when we lose our people, we lose them in really big ways. We lose them to incarceration or we lose them to death. And so we can't abdicate responsibility. It's really vital that we engage in care that will bring people in and trust them to be the expert in their own lives. So thank you so much for having me. Yeah.
Hi, Amanda. Welcome. Thank you so much for sharing. I know you mentioned how you could go on for hours, and I promise you we would love to hear that at some point. But yeah, so now we're going to proceed with the Q&A for Amanda. So if you have any questions, I know we have one to start, then we'd love to get into those. So first we have Carmen, who asks, Amanda, is there an oversight organization or community service organizations that advocate on behalf of MOUD MAUD patients whose medical rights are routinely violated at licensed MAUD treatment clinics across the county and file complaints?
That is a really great question. I do know that sorry, I don't know what happened to my voice. There are, and I, of course, when I'm asked a question, then I completely blank on the answer in terms of the organization. There are some advocacy groups around it. I will find them and then circle back around and link them out. There's definitely organizations, but I think there's also there's different belief systems around medical rights kind of at these treatment spaces as well, and kind of access to MAT. And so I think that's also part of it, is what angle you're going from. I know that there's a real lack of oversight for private rehabilitation centers. I do know that there's supposed to be a reporting mechanism through the county or through CARF. However, the oversight, whatever the body is for the credentialed, like the licensed credentialed counselors, there's an oversight body. In my experience, and I worked in private rehab for a little bit, is that unfortunately the oversight bodies do not do anything, and they do something once we've gotten so far, once we've lost X amount of people, then that's kind of when then they might, it feels like it's a reactive as opposed to preventative, or so unfortunately that's kind of it. But there is, through SAPC, like for LA County, I know for Medi-Cal based providers, there's a funding mechanism through the county, but in terms of private, it depends on who that is.
I just heard from Amanda, her computer died and she's getting back on right now.
Okay, Amanda will be right with us. But go ahead and add any additional questions you have.
Break right now. Right. And then we can come back and do Amanda's Q&A after the break. Okay.
So we'll go for a 10-minute break, and we'll return at 10:10, and we'll continue with Amanda's Q&A. So we'll see you then. Hey, welcome back, everyone. Amanda is back with us. So we'll just continue with our Q&A. I know we have a ton of questions. If we don't get to any, I'm sure Amanda will get to them in the chat at some point. But I'm going to proceed with Steve's question. He asked, are there ways we can work with the drug court system to reduce the coercive treatment, or do you think it requires eliminating them altogether?
A really good question. And I thought that I froze. Okay. I was like, wow, I'm doing really well. Sorry about that. I do think there's this, I don't think it's a yes or no question or one answer. I think there's like a yes and. I mean, ideally do away with them. I don't know that that's actually going to happen anytime soon, especially. So I do think there's a way in which we can act. I think we can definitely encourage training. There's a lot of training of judges that need to happen. There's a lot of training of lawyers and prosecutors and, public defenders, defense, et cetera. There's a really, and of course, I can't remember the name of the organization, but there is a really incredible organization I think it's a public defenders union, but it's a group that basically ensures that there's these issues, that there's training around them, and they go and they disseminate these trainings through the court. I think that's kind of at the moment what we need to be doing, is at least providing the space that they can have a little bit more understanding, do these trainings, come and talk to us, provide like some form of technical assistance, I guess, so to speak, in the meantime. But yeah, I mean, ideally bye drug courts. But I think knowing the world that we live in, that we're probably going to have to do the smaller steps first. And so I would think that, contacting your local probation, police, all the systems that interact with it, and discuss what their understanding is, and if they're willing to engage in conversations and trainings.
Okay. And then next we'll move on to Autumn, who firstly just wanted to say, as someone who's spent time at a treatment center and had a period of abstinence in a 12-step program afterwards, thank you so much for the understanding, validation, and advocacy. That was to you, Amanda. So for her question, I understand many people who use drugs have their children taken away because of the current illegality of drug use and the belief that a person who uses drugs is unable to care for children because of their drug use, which of course is untrue. Are there any proposed avenues for childcare at or provided by overdose prevention programs? Also, what is the discourse in harm reduction surrounding parents who use drugs?
Well, thanks, Autumn. Thank you for that lovely statement, and that's a fantastic question. I think there have been discussions, definitely, I know, for those that are working on the overdose, or we're working around ensuring an overdose prevention facility here, that there were conversations around wraparound services, and that included childcare. There are, I have to say, in defense of some treatment centers, there are a lot of really great PPW programs. So pregnant, post, and those allow for children to come in with their parents. I think up till they're 18. I think you can bring usually 2 children at a time. So there are some places that really do provide this space. I think this is a conversation that I'm continually having. There's a lot of misunderstanding of what actually needs to be reported. And so a lot of people report stuff that does not actually need to be reported. And so I think, again, it's this system of training and things that need to happen. There's a really unbelievable organization, National Academy of Perinatal Harm Reduction. They're a really great organization. They do a ton of advocacy work. I would really highly suggest looking at them. They have a huge resource library on their website. And so they have really great reference points, and also kind of action points that we can be doing. There's also, not to plug my stuff, but next week, there's actually we're hosting a lunch and learn with 2 full spectrum doulas that provide care to pregnant people that are living outside, and ensuring that they actually have equitable access, that they get to their appointments and services, but providing them support all the way through after they've had the child, et cetera, and really working, I think, is a kind of a buffer with those 2 systems. So I will actually put that in the chat later if anybody wants to register and come. It's Tuesday. But yeah, so I think there are definitely conversations in harm reduction. There's spaces. I think there's always room for a lot more space for these conversations, though. Oh, there you go. Thank you, Tucker. And if anybody registers and they can show up, I send the recording after. So.
Okay, and then for our next question from Jerusalem, would you agree that people stigmatize drugs out of fear? How can we dismantle the belief and fear that destigmatization equals promoting drug use?
It's a really good question, and I 100% think it's part of it's rooted in fear, or at least we've been conditioned, to be fearful of it, because then it makes it when you fear something, it's easier, I think, to control than how we want to respond, or how people want us to respond to these things. What was the second part of the question? I'm sorry.
The second part is, how can we dismantle the belief and fear that destigmatization equals promoting drug use?
Oh, yeah. Okay. Again, I think it's conversation. I think it's talking to people in your immediate network. It's talking to everybody, having these conversations and having them repeatedly and normalizing them. And when those conversations come up, asking the person what that actually means to them. I think it's always about really sitting and unpacking, what does fear actually mean to you? Really breaking those questions down. What does enabling look like? What does that mean? What would happen if we are enabling people? What, kind of just really trying to understand how people have come to that conclusion. And I think I used to always take a defensive approach, and understandably, and kind of be maybe a little bit more reactive, and learning now that it takes rapport the same way that I want our, people that we work with to be treated. It takes conversation. It takes a long time. We have to it has to be on the other side too. I think we have to extend a little bit of grace in understanding that we're all kind of conditioned in this system. And it's going to also take a long time to deprogram that. And that we have to be patient there too, and just keep being open to conversations.
Perfect. And we have another question from Ashley, who asks, our residency program is having us present about drugs and alcohol to middle schoolers in our community. What are your recommendations for messaging this to age group other than scare tactics and abstinence only paradigm in our current cultural messaging?
A really great question as well. And you hit the nail on the head. We don't do the fear and stigmatization. I think it's just having a really, really honest conversation about what we know, and also being honest about what we don't know. And so I think it's, what don't we know, what being fully transparent that our drug supply is just so unpredictable right now. And so it's not even coming from, it's not the old fear tactics, it's not the propaganda, but it is just genuine. We don't know what's happening in the drug supply at the moment. And so these are the strategies to employ. Here are all the resources. I think allowing for the avenue for space, I guess, for trust is always going to be that anchor. And so the trainings are hard because it's kind of that one time you're in, like maybe, and you can't really, there's only so much you can say or that people take away. My question, and maybe these usually go to the parents, but my question has always been about centering what is the person hoping to get from that substance, and kind of doing it that way. And so having conversations about what is it that they're hoping to achieve when they're using those drugs. I know that's not like the most straightforward answer, but the reality is you're doing it already. You're asking the questions, and you're not, the safety first, the DPA education is a really great series, but being honest about what we know and being honest about what we don't know, and just kind of being really transparent about these are the resources, this is how you can keep yourself safe, etc. I apologize. That age group is, I work with adults and have really always worked with adults, but when I think back to my teenage years, like what somebody would have said, I wish somebody had asked me what I was looking for in substances.
Great, thank you so much, Amanda. Unfortunately, that's all we have time for the Q&A. I know that there are a couple more questions in the chat from Daniel and Carmen, so if you want to take a look at those and maybe just send a quick message just to get those questions answered, or I'm sure Amanda is always open to emails. But yeah, we all very much enjoyed your talk. Thank you for everything you do for our community. And I'm going to turn it over to Tucker, who will proceed with the rest of our conference agenda.